As Sir already discussed today morning, that HDS is unique as it has got a multivarious kind of personalities altogether. Well, our scientific sessions are also designed that way. Now, the first scientific session today is Managing Diabesity in 2020. Now, diabesity. This word itself, I think, is the most threatening combination in this era. I guess that insulin resistance, diabetes, and obesity form a beautiful love triangle. And they have threatened mankind in a wonderful way and in a very big, alarming way. Well, to listen to that particular topic, I would like to welcome Dr. Sayak Roy, who is MBBS MRCP PG Diploma in Endocrinology from UK. He is a visiting consultant from CMRI Kolkata. He has 8 national publications, 1 international publication, and also poster presented in 2019 at Berlin at ATD conference. Well, to chair the sessions, I would like to invite on stage Dr. Professor Subroto Pal, who is a renowned internal medicine specialist in Shibpur area. He is having an experience of over 20 years and has a membership of API, the Association of Physicians of India. Along with him, I also welcome Dr. G.P. Bhattacharya, who is Assistant Secretary of HDS, as well as we all know him. He's a renowned practicing physician and diabetologist in Howrah, attached to various hospitals and nursing homes. With this, I welcome the speaker and the chairpersons for this session. Thank you.
Good morning, ladies and gentlemen. After the mesmerizing performance of Paragda, who happens to be my senior from my school days, will be starting the real academic session right now. And for this, the first speech has been will be delivered by Dr. Sayak Roy. And the subject is very apt. It's diabesity. Now we know diabetes and obesity are associated for a pretty long time, from the good old days of syndrome X coming to metabolic syndrome, and now the diabetes and obesity are very much associated. Now the first data that came in from the groups that were those who are performing the bariatric surgery, that remission of diabetes is actually possible after you lose a substantial weight. Now later this data was substantiated again by the groups who are working with extreme calorie restriction and weight loss for about say 15 kgs. It has been found out that after even regaining say about 5 kgs after losing 15 kgs, you can still maintain the remission. We have got an apt speaker to deal with the subject. As we are running behind the schedule and take too much of a time, and ask the speaker to stick to his time. Dr. Rai, please.
Surely. Thank you, sir. Thank you so much. And obviously, I'll be very short and brief. So, today the topic is diabesity. Simple terms, diabetes and obesity combined together. So, that's a dangerous duo. Agenda will be introduction and epidemiology, harmful effects of what happens to our body when there is increased weight gain, and what are the BMI classifications for the Caucasians as well as for the South Asians and Indians, and weight loss pharmacotherapy as well as the diabesity pharmacotherapy, because these two are actually interlinked with each other anyways. So, and the special focus will be on lorcaserin, which is a very, very new molecule in our day-to-day practice. It has come very recently. So, diabetes, this obesity, is not a new thing. It was told by our Sushruta many hundreds of years back. And now he said at that time that obesity is a disease, and it was because of physical inactivity, excess amount of consuming of food and drink, which we all do today, and sleeping throughout the day. Actually, he was talking about the OSA also, the obstructive sleep apnea, when we get the daytime somnolence. He was trying to say something like that. And finally, what Sushruta said hundreds of years back, 2030 now, Uncle Sam said, okay, we can stamp that as a disease. So American Medical Association finally said, it's a disease. It's a disease, and with multiple pathophysiological aspects, and requiring a range of interventions for obesity prevention as well as treatment. So what he said hundreds of years back, now it's a truth. And we are dealing with obesity as well as diabetes, both together. And India, we are great in terms of leading the way in terms of pathological problems. Like obesity is third, India is ranking third, and diabetes, India is ranking second, just behind China. Maybe it will just take it over, or cross it over within coming 5 years. What happens when you're obese and comorbid conditions? Obviously, you're going to have from brain, you're going to have stroke, cataracts, intracranial hypertension, that is idiopathic, obviously IIT, and coronary artery disease, and the metabolic syndrome, including the diabetes mellitus. You have hypertension, dyslipidemia, the atheroma formation everywhere. You can have peripheral arterial disease, you can have phlebitis, you can have osteoarthritis. Everywhere you're going to have some problem, and the metabolic milieu is nowhere. You're just having a disrupted metabolic milieu, completely disrupted. The inflammatory markers are way up. You are much more predisposed to develop coronary artery disease as well as nephrological problems as well as other problems, whatever. So try to tackle obesity. And the major problem which I face in my clinical practice, and I guess all of you face also, whenever I give a medicine to reduce the weight, স্যার আমার ওয়াইফকে না দেখতে খারাপ হয়ে যাচ্ছে, কেমন যেন রোগা রোগা লাগছে। কে বলেছে? পাশের বাড়ির দাদা বলেছে, পাশের বাড়ির দিদি বলেছে। আরে অদ্ভুত! Let her get the appropriate BMI. That's horrible. That's a typical approach that we face. People want to see their people healthy, like this. But this is the appropriate weight that you should maintain it. Within 23, not 25, as per the Caucasians, because we are South Asians, we are genetically much more predisposed to higher degrees of coronary artery disease as well as nephrological problems. So, in fact, with increasing obesity or diabesity, the heart failure rate increases by like 6%. So 6% heart failure risk is increased with 1 kg change in weight. That's horrible. And this is our target. Not only I'm talking about dyslipidemia or diabetes, but I'm talking about the diagnosis and the targeted approach of weight loss. That is metabolic syndrome, you can have a 10% weight loss. Mind it, keep it in mind, it's not a just immediate effect. We need a sustained weight loss, and that needs to be sustained, and we have to prevent the weight gain also when we are taking back the weight lossing properties of the drugs. So that has to be kept into mind, because it's a long-term goal that we have to achieve. It's not a short-term goal. So metabolic syndrome, 10%. Type 2 diabetes, with type 2 diabetes, you should be getting a 5 to 15%. In fact, 1% is also great. In reducing 1% of HbA1c reduction as well as 1 kg of weight loss will give you a huge amount of benefit in terms of reduction of the microvascular complications. Dyslipidemia, 5 to 15. Hypertension, 5 to 15. So this is a fantastic approach of your targeted weight loss. How much weight loss should be there over around like 1 year? This is the Caucasian classification. Underweight is less than 18.5, normal 18.5 to 24.9, and obviously you start getting overweight. The patient starts getting overweight when he's above 25 to 29.9, and above 30 they have got the different grades of BMI and the different grades of obesity classification, obesity 1, 2, 3. India, we do not need to think about all this stuff. Just keep it in mind. 23, that's it. More than 23, you're obese. More than 23, you're overweight. 25, you're obese. That's it. So that's the most important thing. Why? Why suddenly WHO started doing, gave us a low BMI cutoff? Because we are genetically predisposed. So we need much more interventions much more earlier than our Caucasian counterpart. That's what, when it comes down to the YY paradox, the Caucasian and the same Indian having the same BMI, but when you assess the visceral fat, you will find a very high amount of visceral fat, and that's disastrous. The visceral fat, the abdominal adiposity is disastrous for us. So this is what I was talking about, the YY paradox. The same BMI, but the visceral fat is much more increased. So very typically they are said the thin fat Indian concept or the Indian phenotype. Nowadays we say Indian phenotype. So this is for the Indian fellows. It has increased from 13 to 50% in urban population. 13 to 50. It's not a matter of joke. And 8 to 32 in rural population. So everywhere obesity is increasing. And obviously obesity will bring up all the things with its own hand. So overweight, BMI is more than 23, and obesity when it's more than 25. That's it. We do not need to have to classify obesity type 1, type 2, type 3. Just obese, that's it. Enough for intervention. And etiology, keeping aside the genetical counterpart, the genetical part that we have in our genes, the other things which we can actually modulate, the food habits related to the abdominal adiposity, excess amount of refined fat. লাল চাল কাউকে খেতে বলুন না, দেখুন না পেশেন্ট কি বলে, লাল চাল, ঢেকি চাটা চাল। প্রথম কথা তো পাওয়া যায় না, you will not get that লাল চাল or the red rice. Even if you get the red rice, it's very bad to taste, horrible. It's not because of a taste. You want to taste that for your life, you want to live a longer life, then please take the brown rice or the red rice, whatever, but take the calorie less. At least do not go for the very high refined starch with high glycemic index and also the glycemic load. So both things are very important, not only the glycemic index but also the glycemic load. So divide that amount. Obviously I'm not a dietitian, so I cannot be saying more amount on this one. So frequent intake of fried snacks, pan-fried momo, that's very important, right? We often take that. Momo was there. I don't know where from the pan-fried momo came in. So that increases all the problem. The pan-fried, whatever you are having, that portion will increase the cardiac problems, the nephro problems, the inflammatory markers will be there. So that is important. Use of oils, saturated oils actually, that is used for cooking, and increasing amount of sweetened beverages that we take, and westernized calorie foods, that's the processed foods. They should be avoided. The processed foods should be avoided. And this is a very interesting one that I found in one of the journals, that as per the upper BMI is for the Caucasian counterpart and the lower BMI is for us, that is for the Indians. So they have combined both of them together. Diet, lifestyle is a cornerstone of therapy for obesity as well as diabesity, both. Whatever BMI you are having. Then added on to drug, when you're using drugs, you can use it when it's more than 25 if you're an Indian. But for the Caucasian, it's better when you're using it with like BMI 27, because that is when they are saying the patient is having obesity. So in fact, we do not use this for bariatric surgery now. We now say it's a metabolic surgery. The term has changed. It's now metabolic surgery. Why metabolic? Because it's not only mere cutting your stomach, but that sleeving, gastric sleeving will actually lead to tremendous amount of shifting in your metabolic milieu. Inflammatory markers will be coming down. There is a endocrine hormonal axis is there, which is a very large endocrine system of the body. So everything will be changed. So not only a bariatric surgery, it's a metabolic surgery nowadays which we are performing. Initial guide, again this is for the Caucasian population which we mentioned, and the treatments for the obesity of Indians as well as this is applicable for the diabetes, that is for the diabetes and obesity also. Diet, we said individuals hypocaloric diet, clinical workup, lifestyle management will be there, physical activity should be there. Now drug therapy, we are interested in the drug therapy because that is where we are interested and we are actually working on. So orlistat, we know it was there. Lorcaserin is a very recent drug that is available in India, like maybe 4 or 5 months now. And liraglutide, I do not know whether Saxenda is still available. I don't think so Saxenda is still available over here. So it will be maybe because they have submitted the things to the DCGI, but that will be a time-taking process. Till that time, well, it's up to you. You can use liraglutide to the full dose, like 3 grams. And judicious use of metformin and SGLT2 inhibitors. SGLT2 inhibitors in diabetic patients is always a fantastic approach, if they can afford. And GLP-1, definitely they are the best if the patients can afford, but they are costly. That's the only problem. And bariatric surgery, I will say metabolic surgery, for patients with BMI 32.5 in presence of comorbidities or 37.5 in absence of comorbidities. So the objective of the anti-obesity treatment should be improve of the health of patients and the improved weight loss of the patients, and the ideal body obesity drug would produce sustained weight loss. This is very important. Not a rapid weight loss, but a sustained weight loss which has to be sustained over like 1 year, 2 years, till the dose you are giving, till the time you are giving, with minimal side effects. See, anything will have side effects. That's normal, but that should not be disastrous side effect. Okay, that's the main thing we have to keep in our mind. These are the things, and the most robust contribution is seen in the phentermine topiramate extended release combination. That's a fantastic combination, but sadly that is not available in India. So obviously you can use topiramate to like 50 to 100 in off-label prescription, but that depends on you how you take the risk. And lorcaserin, it's available like 20 milligram, which we are using in non-diabetic and diabetic. As per the Bloom DM trial, you can use within 10 milligram, with 10 milligram OD. For non-diabetic, 10 milligram BD. And orlistat was there. I don't need to go into straight away with this, with the mechanism of actions, which we all know. Again, naltrexone and bupropion, that's a fantastic combination, but that is not, again, not applicable, that is not available in India. And liraglutide, like I said, the Saxenda is still not available, but will be available very soon. So, right now, the anti-obesity drugs that we have in our hand, typically anti-obesity, I'm saying, not anti-diabetic molecule which is causing weight loss. Anti-obesity drug is only orlistat, and we do have lorcaserin, and in very few, I guess, we can use topiramate as well as bupropion we use in some of the patients. So, when we are talking about the anti-hyperglycemic agents or the oral hypoglycemic agents, actually oral glucose lowering agents should be the term, not hypoglycemia, because SGLT2 and DP4 inhibitors will not cause hypoglycemia. It will bring down your sugar. So oral glucose lowering agents should be the term. Anyways, for sulfonylureas, glinides and thiazolidinediones, we can see increase in weight. DPP4 inhibitors, metformin are normally weight neutral metformin. With metformin, you can get a maximum of 500 milligram of weight loss. AGIs, yes, if you have stomach upset or something like that, you can get as weight loss, but not actually meant for weight loss. The two things in case of anti-diabetic drugs which will cause finally weight loss will obviously be the GLP-1 receptor analogs as well as the SGLT2 inhibitors. And this is the pathway of GLP-1 receptor analogs. We have liraglutide, we have exenatide, we have dulaglutide. We have strong HbA1c reduction because it will be acting through pancreas, through the brown adipose tissue, skeletal muscles, as well as liver. So it acts in all the spheres. So it's a fantastic molecule, provided that you can, actually make him ready for the injections. Because most of the patients will try to avoid any type of injections, but it's a fantastic molecule, again I'm saying, if they are ready to take it up. SGLT2 inhibitors, we now use it like anything. And after the ESC guideline 2019 held in Paris, they have recommended in drug-naive patient instead of as the first line for high-risk patients. Mind it, for high-risk patients, not for all diabetic patients. For high-risk diabetic patients, they have recommended GLP as well as SGLT2 as a first line instead of metformin. That's for the ESC guideline, not anywhere else. So Endocrine Society has not yet recommended, and I do not know whether they will recommend it in next year also. So whatever be the situation, till date we use metformin and add on, at least try to add on, the first drug will be SGLT2 inhibitors or GLP-1 analogs, provided that you're choosing the right patient. You're not taking up a LADA, you're not taking up type 1 diabetes, then you will be having some issues with the ketosis. So this is again the mechanism of action of SGLT2, which we all know, and focus on lorcaserin, because this is the newest molecule, the newest baby. Lorcaserin is, we have number of 5-HT receptors, 2A, 2B, and 2C. 2A will be deleterious because of the psychological issues that we have, that we also had with the other molecules, where the molecule had to be taken out because of the increased suicidal attempts. Then 2B in the valves of our heart. So more specific 2C is best for your patients. That will bring down your appetite taking habit, and that will bring down your calorie intake. And that's how normally they try to address your obesity problem as well as your diabesity problem. Why am I saying diabesity? Because lorcaserin in the Bloom-DM trial, they included normal glycemia, pre-diabetes, as well as diabetic patients. The fantastic outcome was that, because in the TIMI-61 trial, which was given out which was rolled out in ESD, I guess, in 2017 or 18 in Portugal. So that was the molecule, the first anti-obesity molecule having CVOT, and it showed decreased new onset of type 2 diabetes from pre-diabetes as well as normoglycemia. So this is a drug which has addressed this problem of diabesity to a huge extent. Pre-diabetic patients are not turning into diabetes, provided that the patient has obesity at baseline. And as it is targeting the 5-HT2C receptors, we are least likely to have any type of psychological problems or the valvulopathy. In fact, when I'm talking about valvulopathy, randomized trials were done, and FDA was very, very much concerned about the valvulopathy problems with any type of anti-obesity drugs, which we used to see with others. So they said that you have to go for this one. This is a slide. Phase 3 trials, patients were evaluated for the valvular heart disease, and everywhere it was seen that there was no increased risk of valvulopathy, which was seen with the other anti-obesity drug. And this was a summary of the TIMI-61 trial, which showed did not increase the risk of MES, as well as there was decreased incident new onset diabetes in patients having pre-diabetes or normoglycemia. And the most important thing, it reduced the risk of diabetic microvascular complications. So that's very important. Again, this will be addressing your obesity. That means it will bring down your inflammatory markers. Maybe the whole system is acting upon to bring down the microvascular complications. It's not the molecule per se. So we need much more data to say that. Till then, we have to keep on doing research works. And this is the thing, when you're using lorcaserin, these are the things which you should be cautious when you are using lorcaserin with something like that. SSRIs, tricyclate antidepressant, TCAs, triptans, lithium, St. John's wort, we do not find that over here, and tramadol. Tramadol also can also cause serotonergic syndrome. Tramadol, increased dose of tramadols. If a patient is having nephrological problem, like stage 4 or stage 5 CKD, and you are using a very high dose of tramadol, the patient can have serotonergic syndrome if the patient is already on SSRI or you are using lorcaserin. In fact, lorcaserin should not be used less than 30 eGFR. It's recommended above 30 eGFR. So this is a study which actually I am doing. So this is a prospective observational trial I'm doing with lorcaserin. And this is, till date, I'm targeting 100 patients. Till date, I have found 82 patients. Yesterday, I got 83. The number is risen to 83. HbA1c, so 56 are diabetic patients. The rest are non-diabetic. I'm using it with combination of topiramate or without topiramate. Migraine patients with topiramate and without topiramate. I want to see whether there is some extra advantage when you're using with topiramate 50 milligram. And this is the pair t-test, the interim result after 45 days. The pair t-test showed me a fantastic reduction of weight as well as BMI. And I'm also seeing the ketone body, the beta-hydroxybutyrate. Why? Because most of the type 2 diabetic patients, I am putting them on this lorcaserin are already on SGLT2 emitters. So I just want to see whether there is any increased risk of ketosis when I'm using lorcaserin with auxiliary inhibitors, but thank God that there is no such increased risk, at least till date. And weight change, be it diabetic, be it non-diabetic, everywhere the p-value is significant. Though the number of patients are still less, and definitely I'll be getting the results maybe within 3 to 4 months. Till that is very encouraging, whether you are using with topiramate or with non-topiramate. Everywhere the p-value is significant for diabetic as well as non-diabetic patients. So the take-home message will be, is a disease, obesity, that needs same intervention as diabetes itself. GLP-1 receptor analogs and SGLT2 inhibitors are the molecules with the maximum benefits in controlling glycemia as well as obesity, as well as multiple benefits out there. Sustained weight loss and the prevention of weight gain when you are stopping the anti-obesity drugs. LSM, cornerstone of therapy, lifestyle modifications should be there. Amongst the new drugs, lorcaserin has an advantage of decreased transformation of prediabetes to diabetes. So thank you so much, and this is the prize question that we have. Which is the BMI cutoff for South Asians to define overweight? Yes.
It is 23.
Thank you. Correct. Thank you.
Thank you, sir. We have a gift for you.
So I think I was in time.
So
It was
kindly
over.
introduce yourself.
Ja.
Yes,
I'm Dr.
thank you,
Somnath
Dr. Rai,
Nashkar,
for the nice
Assistant
deliberation.
Professor, Bardhaman Medical College. I'm from Howrah.
Thank you, sir.
I would like to open the session for question and answers. Please put forward your questions to Dr. Rai. And for time constraints, we would allow 2 questions.
Okay, so we'll allow 2 questions due to time constraint. Our first question.
Thank you, doctor, for your excellent deliberation.
Yes,
Is
now
there
receive.
any hepatic or renal adverse effect of lorcaserin?
I didn't get you.
My question is, any hepatic or renal adverse effect of the lorcaserin in patient management?
Renal or hepatic?
Any adverse
Safety data. No, renal data till 30 EGFR is approved, not below 30, because data is not there. And hepatic safety, I don't think that there is any data on hepatic problem. Yes, we do not use any type of new interventions in child PUC 3. Child PUC C, child PUC C. So up to A or B, we can use it. Yes, sir.
I have got one question. In view of the YY phenomenon, what is the relevance of BMI nowadays?
YY phenomenon. Yes, sir. Thank you so much. That's why, sir, I said that WHO has given the BMI of 23 for our South Asians, and cutoff still now for Caucasians is 25. And we should be using waist circumference as well as waist hip ratio, which is a better indicator rather than the BMI itself.
Exactly.
Thank you, sir. And now,
Thank you.
anything
There are
else?
no more questions. I would like to call off this session. Thank you for the speaker, and from
Thank you so
our
much, sir.
desk. It's okay.
Thank you, speaker, for the wonderful session, and thank you, chairperson. Sir, I would like you to wait here for a few moments because we have a small token of appreciation for you. And to give away that, I call on Dr. Bismay Kumar to come up with us. Thank you so much, sir, for the wonderful session. And now for the chairpersons, please.